Thank you very much, Amy, and thanks to all the panelists for really terrific comments. Many nuggets and action planks included in the comments. We're going to go till 4:30, and then there's a reception at 4:30. So keep that in mind. The way that we're going to spend the rest of the time is roughly as follows. We're going to give the opportunity to our panelists to ask each other any questions if they have any that they would like to tee up. Not necessary, but give them the first crack at questions. Secondly, we're going to open it up to questions and responses throughout the room. And again, brevity is a watchword. And thirdly, we're going to pause about 12 minutes before the end of the hour, or when the questions die down, and reserve time for each of the panelists in turn to offer final observations. And we'll start with Amy, since you were the last one in the order. And what we'd like to have you be thinking about between now and the time that starts, it builds off the notion that was stated quite clearly that the status quo is unacceptable. There is no question on that count. It's impairing the potential for progress. So what we'd like each of you to respond briefly to is the question along the following lines. If you had to pick one leadership measure that your by measure I don't mean number, I mean action, that your stakeholder group might undertake to help implement the VitalDirections aims, what might that measure or action be, and how might the National Academy of Medicine be helpful in that respect down the line? Very short, and we'll come back to that in just a few minutes. But first, are there any questions that the panelists would like to address to each other? If not, then you get it. Oh, George's has got his.
Yeah, let me, Judy. I know we were talking at lunch a little bit about the experiment you were having around engaging both the healthcare sector and the social services sector. I mean, I think that that's an exciting idea, because there's no question that one of the challenges we have is how do we get the medical care sector and then those elements of government, including the public health sector and the social services sector, to adequately integrate data across those sectors, asking the right questions that measure, the right measures that matter, to solve really, they seem to be complex problems, but in many ways they're simple, because they're things that we're dealing with every day. Some thoughts about that?
Well, just to back people up a little bit, in Finland, that's a country that really spends a lot of their energy not just on healthcare but on social care, and puts the two together into one system, and that's what we're doing there for them. And then we're going to see if it has validity back in the U.S. and whether that will work here as well. I think that's going to be a very interesting experiment. So far, I hear it's going quite well. One of the downsides of it is that each country isn't just the healthcare side of social care, it's the financial side of social care too. So not only do you have to keep track of the patient's health, but this organization charges this way, they're paid by the government, but they each have their own charging methodologies, and that is not an insignificant or trivial component to program, and that is not generalizable or transferable between the different countries. So that does cause a burden to the whole thing. Did you have something to?
Yeah, I just wanted to add that, we've gone to a quadrant now where we can take and begin to look at the social, the employment, the housing, the emotion, the mental, and put that in and be able to predict, for example, with unbelievable accuracy, who's going to get readmitted to the hospital. And so we're charting that regularly on all of our hospital admissions.
And if I could add to that, one of our healthcare organizations in Texas is keeping track to the block, which is that 9-digit number, which I'd really like to be able to keep, the determinants for child abuse. And so they can figure out exactly which blocks they need to go into and help the parents so that they don't have as many child deaths from child abuse. And they look at history of child abuse, murders on that block, and several other things. That there's 5 out of 100 things they looked at, 5 of them were predictive.
Thank you, Georges, for the question, and Toby and Judy for the...
Yeah, I'd like to ask Victor. I was surprised when I read this that of the determinants of premature death, about 10% of them are healthcare, about 40% are societal, and about 30% are genomics. There's almost no mention of genomics in this report, and I can envision the day, frankly, where every child at birth is sequenced. And I think that as that is one of the predictors of premature death, I think that probably is something that we ought to think about for our future.
Would you like to answer that, Victor?
There is a chapter paper on precision medicine. In fact, I wrote it with
Yes, which Victor wrote.
Sorry?
So which you wrote.
I thought I'd tee you up there for this.
And in fact, clearly that's the potential. Because gene sequence is only one of the tools, as we know. But I think that chapter, again, because it's oriented towards policymakers, talks about evidence generation, talk about economic impact, cost effectiveness, talk about payment and approval processes, and the kind of things that we need to do to facilitate the development of precision medicine. So it's in there. Thank you.
If I can add to that, actually, in several of the infrastructure elements, the notion of progress that's based on genetic information and the relationship between genetic information and other epigenetic influences is embedded, whether it's the measurement piece, standardized measurements across the board, or the evidence from real-world insights, or the issue of building the future science for the 21st century. So it's, although it's not called out explicitly, it's implicitly embedded everywhere. Yes, Jim?
I just wanted to emphasize what Michael just said. There are populations that are fairly homogeneous in terms of sequence, but their environments create a very different transcriptome. And examples of that would be the Pima Indians, which in a natural environment with a natural diet have virtually 0 diabetes. On a Western diet, have virtually 100% diabetes. Another would be the Barbers of North Africa, which are by sequence fairly homogeneous, but whether they're coastal, urban, or rural, have very different disease burdens. So I just want to make the point that we talk about sequence and also mean things beyond sequence like transcripts as well, because if we have sequence alone in the absence of that context, that would be the definition of depersonalized medicine.
Thank you, Jim. Did you have a question, Laura, from the field, or?
From the webcast.
Okay, just one last question here, or opportunity for the panel. Any cross questions? Okay, let's go to the webcast.
Okay. Governor Leavitt and others have acknowledged the major disinvestment, more than 30 to 40% reductions in public health that's been occurring for the past decade or two. Public health at state and local levels increasingly are using strategic approaches such as health and all policies that partner with land use, housing, education, agriculture, and transportation. Does VitalDirections propose any major investments or new financing approaches to better support public health?
Thank you, Laura. Georges, do you want to lead off on this?
Yes, the paper has certainly said 2 things. Number one, that we actually do have to define exactly what we want to get done, that we have to adequately fund it, and that we have to figure out ways to sustain that funding. And there are a lot of new innovative models. The Academy actually has a report which looked at public health funding in a variety of settings, and recognizing that it is both a federal, state, and local partnership start with. And then the other part is, what is each partner's contribution to that? But in addition to that, it doesn't all have to come from government. because there are a lot of other partners that can adequately participate in that partnership, but it needs to be goal-directed in terms of improving our health. And then aligning those incentives and the funding to achieve those goals in a strategic manner.
Thank you, Georges. Just to elaborate a little bit on George's wonderful answer, the two aspects of the report which people have talked about, the payment for value and the community-based initiative, clearly underscore the vital importance of public health. For example, if the payment system moves toward a value orientation that rewards population health improvement, not just individual health improvement, but in a fashion that places value on the broad population, obviously that'll provide incentives. And in addition, the notion of activating communities is inherently focused on recruiting both public and private partnerships in that respect. Yes, Sally.
I would echo everything that was just said, but I would also caution us to not fall prey to the notion that we can apply some of the same principles across all of our public health communities. We really need to be paying very close attention to the nuances of communities, the cultural issues that are going to be inherent in those communities, and really don't fall prey again to the siloing of things that we have traditionally done in the past by trying to solve problems with one sort of blanket approach. I actually would call out Dr. Leanna Wen in Baltimore, who I think has done an amazing job in sort of collaborating with the community members as well as with all of the businesses and different groups within that community, with faith-based communities and others, to really recognize just how critically important it is to know the neighborhoods, know the people, and then bring some of the issues that they identify as being the barriers or challenges for them to have health and well-being to the table in a way that actually the kitchen table moves beyond the home and it really sort of expands into the community.
Yeah, it's the concept of practicing public health with the community and not on the community.
Yeah, exactly.
Right. Thank you. Yes. Can
Hi there.
you tell us who you are?
Yeah, Nathaniel Counts, Mental Health America. And I was wondering, as we work to do like sort of, breaking down silos and doing collective impact at the community level, I was wondering what your thoughts are about how we design policies that reify the concept of community, because it sounds, I guess, easy to say, but then when I think about my own community, I don't know any of my neighbors or have a sense of community. So it seems like something that always exists somewhere else. And if I were to create a policy to do like equitable participation in community level population health, I wouldn't necessarily know what to do.
Thank you. Someone would like to, Jim?
I'll just give one example. So the one thing I mentioned was the CMS actuary's decision to count prediabetes programs that prevent conversion to diabetes in a positive way from a financial standpoint, allowing these programs to be reimbursed. You take a community organization like the YMCA, they were very involved in prediabetes prevention, very worried about the cost there, whether there could be reimbursement, and starting to find linkages between prevention and payment as exemplified by this one policy is one way of making the connection.
Thank you, Jim. Sally?
I would say that really the other piece here is that we have such an opportunity with 21st century technology. If you think about the ways that we can activate communities via social channels and those sorts of avenues, there's endless possibilities. As a community-based provider for many years, we used to coalesce around the potluck dinner, bringing people together to discuss certain issues and problems, and that was really quite powerful. Some of what I do at Patients Like Me, sometimes when I want to get an issue sort of out into our community, which is about 500,000 members today, I'll put sort of like that potluck dinner mentality into our forum and sort of say, here's what I'm trying to get at. Can anybody give me some insights into this particular issue? So I think, don't underestimate the power of activating communities in novel and unique ways, using technology that actually helps to connect you to your neighbor. Even still, you may not even meet them, but the opportunity to be able to do that in novel ways and actually systematically collect information as you're doing it it in a way to continuously learn about what the issues are within that community. And I would again just say that for patients like me, we have about 500,000 people today who are activated and empowered and who are activating a community. If I were to go out to them and identify, different groups around the country to say, I want you to activate your individual community, I think they would stand up and say, sure, what's the message you want out there? So again, I think if we start thinking about health and well-being as the national conversation topic, how does that get interpreted across different environments and different communities? Each one of us would have our own community network that we could be reaching out to technologically as well as in in-person ways.
Thank you, Sally. Laura, another question?
Yes, this is a question from the webcast for Judy. It says, now that clinical data is beginning to assist in the assessment and treatment of populations, what do you think is the best way to harmonize that with additional data and AI that is not captured by the clinician, for example, socioeconomic status, education, and environment? Is this something that needs to make its way into the EHR for analysis?
I'm not sure what's meant by the best way to harmonize it. What we're doing is keeping it for each person for whom we have data, so that we have the healthcare information that's collected from the electronic medical record, but as much of the socioeconomic and sociodemographic information that we can also put in for that patient. Then it's just there, and how people use it to come up with their conclusions, it's going to be there.
Another way of phrasing that question might be, and I'm just guessing here between George's and Judy, would be the extent to which data on socioeconomic status and a variety of other population health indices that the public health department may have or other community agencies can be seamlessly integrated into the EHR.
Yeah, well, New York State did a good job of making its public health data a whole lot more public. And of course, HHS, who the last two administrations have worked hard to try to make that data more available. But the challenge is there's still only a few people that actually know how to utilize the data. So, but making that data more publicly available, letting people use it for a whole range of studies and for community engagement is very, very important. And it's not always the data that you may think it needs to be. It's nice to know what your diabetes rate is, but if your community goal is to get more people out walking, it may be more important to know what communities have packs of wild dogs, because that very, very much can be the central barrier to getting people out and walking. We talk a lot about sidewalks and building communities. Absolutely true, but in some of our communities, it's the pack of wild dogs. And you have to ask the community what their barriers are to getting out and walking. So it's that kind of information that is sitting in a repository of maybe animal control that has to be released, as well as the health data and the architectural data, et cetera.
Thank you. Judy, did you want to follow up on this?
Yeah, I would. One of the things we heard earlier was put public health back into the state's jurisdiction. And one of the big problems with that is that means that each state typically ends up with different formats, different structures, and then trying to have the electronic health record pull in all that data when everyone is different is a huge barrier. And we've already run into that with immunizations, in that different states have lots of different immunization technologies that they use, and there is no one that we can just say is nationwide, and immunization data is very important. The other thing that I would add is I would hope that when we get into doing all these things, really focus on kids for the future, and I think there's two things there. George Halverson from Kaiser said that children who don't have a certain vocabulary by a certain age, and I don't know exactly what the number of words is by the years, I think it's probably about 2 or 3 years old, will have a 70% chance of going to jail. And the second thing that I think is very important is that we try to combat childhood obesity, because if we can't do that, we're going to be stuck with the same chronic diseases forever.
Thank you, Judy. We have time for one more short question, and then we'll start with Hammy and go down the row here. Yes.
So we talk about, I'm Martina Boitis, I'm with HealthChamp. We are in the data interoperability, working on the problem. And when you talk about data coming in from multiple sources, that's outside the EHR or outside the health systems database. And so there's two ways we can homogenize that data with data that's outside. We can either bring in the data into the EHR and then analyze it from there, or we can access the data from the EHR and the outside. And from that point of view, which is more what we are looking at, is how do you see going forward the access, both technically and commercially from a business point of view of how that might work out.
Any responses? Yes.
I think because it's a sort of a follow-on from the last question. And my point of view is that lots of data is coming from lots of places that is not in the electronic health record. Judy has a tremendous amount of data, but we have watches that we wear on our wrist. We have phones that collect weather data. We do have genomics data. We do have data about claims data. We have data about prescription. What actually can happen is you could all put that in the electronic health record, or you could collect that as an individual yourself, give access to people to have access to that via blockchain, create a secure connection between yourself as a patient and your primary care provider, provide that information to him, provide it to a researcher, provide it to a specialist, and then have the data read that way. And augmented intelligence will help as well to read through what this massive amount of data between your electronic health record, your genomics data, your social determinants of health data, the weather data can tell you about what's going on in your system. So technology is making it possible now that an awful lot of data is collected not in the electronic health record, and it would likely be too much of a burden to get it all in there.
Toby, did you have a follow-up on this?
Yeah, I would just like to say the follow-up of this explosion in data has been the adverse effect that it has had, amongst other things, on the care providers. The burnout rate right now in physicians across the United States is 54%, and going up, and that's about double what it is in the general population of working individuals in the United States. This is a serious issue for everybody who is in the healthcare delivery system, and I think it really boils down to 4 changes. 1, the loss of autonomy. 2, the changes that have been brought about in the pay system and the quality metrics that go with it and the cost metrics that go with it. The third is the electronic medical record and the things that we're asked to record, and finally the explosion in data. We have to learn how to handle these, or we're going to drive the efficiency and the mental well-being of our care providers in the wrong direction.
Thank you for raising that, Toby. I should mention that several of the folks in the room, including Jim Madera and others, are involved with our Action Collaborative on Clinician Resilience and Wellbeing, which is obviously an essential challenge for the nation. Quick comment, and then we'll go to Hammy.
Yeah, I really want to reinforce the notion that we have the capacity and the technology today to start thinking about a person-controlled record, very much along what Deborah was describing. And I think that the appetite for something like that is going to be increasing over the next couple of years, and our ability to be able to protect that data coming in from multiple streams and having it be something that people themselves can actually have that immediate access to and bring with them to their providers, so that there isn't necessarily this need to have the provider being the one who's got to marshal all of that information. So I think that's the direction we should be going in. We have the technology to do it, and people are accustomed to that kind of seamless way of approaching things like finances and things like that. There's absolutely no reason why we shouldn't have a person-controlled record.
Thank you, Sally. We're now going to go to our concluding lightning round, if you will, in which each of our stakeholder leaders is going to give a brief comment in answer to the question, if you had to pick one leadership action that your stakeholder group might undertake to help implement the vital directions, what would your most important candidate be? And how might the National Academy of Medicine help to facilitate that action? Amy?
Great. So I'm glad to start. So one of the things that really resonated with me when I sort of read the VitalDirections paper was cross-sector collaboration, the focus on social determinants. And from governor's perspective, governors are conveners in their states, and they have the power to bring together lots of different groups across their state. And so I think one of the roles that we could really play is help promote that practice. And states learn from one another. So if there's a successful model in one state, other states want to replicate it. And so figuring out how to really build that success story around that piece, I think would be something that we'd be very interested in. And in terms of how you all can help us is, the paper is a great start. I think it has a lot of important principles in that, but sort of getting even at the layer below that of what are the practical steps that states should start thinking about would be really helpful. Thank you.
Thank you, Amy. Jim?
Well, I think I could name a few, but I'm duty-bound to say something to build on Toby's burnout question around physicians. We've done 2 studies collaboratively with RAND to see what satisfies physicians. And number 1, 2, and 3 satisfiers are time with patients. Dissatisfiers are everything that gets in the way with that. So it's time with patients that's the satisfier and the intrinsic motivator. It's not money or these other things. So we take that study, and then we talk about the time motion study with Dartmouth, where you spend 2 hours doing administrative work for every hour you spend with patients. And then, not surprisingly, in 2 studies we did in collaboration with Mayo, 3 years apart, we show the increase in burnout rising to, as Toby pointed out, above 50% now. And that is kind of burnout is not depression, but it's a sense of loss of meaning in one's job. Not surprising if you're a data entry clerk and you actually train to be a physician and spend time with patients. The unrecognized aspects of burnout are that there is less efficiency, there are more medical errors, there's decreased patient satisfaction, go down the list. And when you think when the burnout is 50%, which is 1 out of every 2 visits, this has to be the largest unrecognized public health threat that we probably face at this time. And underlying this is also having to understand the difference between intrinsic and extrinsic motivators. In cognitively complex tasks, intrinsic motivation is a much more forceful behavioral change, and being a physician is a complex cognitive task. And the behavioral economics literature shows that when you start throwing extrinsic motivators and incentives in on top of that, you can erode the intrinsic motivation. So thinking about this from the standpoint of behavioral economics and the power of incentives will also be important. And for that reason, I think a central organization like the National Academy can be so important. It brings all of these pieces together.
Thank you, Jim. Deborah?
Accelerate real-world evidence. One of my best times in this job was going to one of our provider partners and seeing a breast cancer doctor jump up and down and say to me, you don't understand, this is what Watson gives me. In 30 seconds, I get to know just what information I need to know about my breast cancer patients. And then in the next second, it gives me the clinical trials that my patient is eligible for. The ability to look through that electronic health record, which is thousands of pages long, and pull out the inclusion and exclusion criteria for a clinical trial, and then go to clinicaltrials.gov and match the patient with the trials that she's applicable for, means that that institution, which formerly only offered clinical trials to about 1 patient a week, is now offering it to 6 patients a week. And if you're those 5 patients, you're really glad to have offered of that clinical trial. And if you're the physician who wants to offer it but doesn't have the time, you're glad to have the cognitive technologies that are available. And I'll say it again, we're only at the very beginning of what augmented intelligence can do for healthcare and how we can sift through this vast amount of data that's coming at clinicians every day. And we will certainly work with the National Academy to help make these technologies more accessible and to help physicians through the onslaught of data that they're getting today.
Thank you, Deborah. Judy?
I guess my one choice would be to help physicians be as happy as they can be in the areas that we have some control over. And that would be to work on creating the best system possible, getting lots of feedback from our customers on that, and then to work on helping our users install those features so they can use them. My ask would be that the government should get out of dictating what's in the EHR and how it needs to be used. I was on the HIT policy committee for almost 5 years, and there were so many silos, and each one would want to add to the record what was important to his or her silo, but they didn't understand the effect that the whole thing together would have.
Thank you, Judy. Toby?
I'd accelerate as fast as I could the move from volume to value, and I think that that will be the main thing that puts us in the proper perspective on how we look after patients and improve their quality.
Thank you, Toby. Georges?
Yeah, I'd focus like a laser on the zip code, and with the goal of taking a zip code and taking it from red to yellow to green. And the way you do that is by aligning incentives across sectors to change those perspectives. And I think the Academy can certainly look at the evidence for that and help us scale up that evidence and disseminate that evidence very, very aggressively. But I do it as a stoplight chart. Your zip code has these health characteristics, therefore you're red, these are yellow, these are green, and actually RWJ has already done that with their county health rankings.
Thank you, Georges. Sally, you get the last word.
Oh, well, thank you so much. And the last word from patients is always a critical piece. So Patients Like Me has been working with its patient population for the last year and a half on developing what we're calling a thriving measure. This is a tool that's been patient-informed. It helps us understand what it is that makes them feel like they are thriving beyond health, but just understanding what that means to them. What they've defined this as is thriving is about the life I want to live, and then helping us figure out how to measure that. So that's a tool that we are very close to finishing up. So where we would love the opportunity to work with the National Academy of Medicine would be in sort of facilitating the conversation around this national call for health and well-being, helping us better understand and define thriving beyond our population and understanding how close we're getting to it so that we can start to define that a little better for the a larger group of our population. But ultimately recognizing that real-world evidence that's generated by people themselves is ultimately going to really be the guiding North Star for us, I think, that we really need to be reaching for. So anything that the National Academy can do to help push that national conversation around these health, well-being, and thriving, I think will be a great contribution to not only the work of this project that's been initiated, but also to the lives and well-being of everyday people. So thank you.
Thank you. I'd like to ask Victor Zhao to come up to say the last few words, but beforehand, let's all offer a very deep note of thanks. What an extraordinary group. We're going to very much look forward to working with you in the follow-up.
Well, thank you, Mike. You did an extraordinary job in putting this together. I'm going to be very brief. But this last panel, we've asked experts without rehearsal what they think about the VitalDirections. Yes, some of them were involved in writing, but most of them actually are seeing it for the first time. And I think there's tremendous consensus around, I think, the message we get from them, which is, okay, we are really at very interesting, contentious time around this repeal, but there is, in fact, work to be done by all of us to make sure that we stay the course and really, in many ways, increase the awareness of what needs to be done. As the President said, healthcare is complex. That being said, I think we heard a lot about shared vision. We want the same things. And if you look at the 4 priorities and 4 infrastructure, in fact, all of them spoke in some way or the other, from data to providers to connected care to activate community, health and wellness, and patient involvement. So I'm very grateful to them. I do think that what I'm hearing is solutions have to come from us as well, and we better be the voice of pushing for the right one and work together. Solutions should be collaborative. It's a balance between federal and local, and certainly we need to strategically deploy the resources, because really a lot of resources put into it. How do we use it? And of course, I certainly believe that science and technology is going to be a very effective way of future if we do it right. So I just want to make sure that not only I thank the panelists and for the steering committee, and of course Mike McGinnis, but also Liz Finkelman. I don't know where she's still here, running around. Yes, she's the best. And Laura DiStefano and all our wonderful staff who make this happen. And thank you so much. Please join us at reception. Give us your feedback. I would say the National Academy is here to try to do the right thing. As you heard, we are doing one on clinician resilience as well. So let's push forward together. Thank you very much.